This afternoon we're going to talk about GU cancers, and it's a very, very large topic, so I'm going to do my best to condense it into a format that we're going to be able to just get a brief overview of all of them and the concepts of treatment and why we do what we do when you guys rotate with us. So I want to discuss prostate cancer because it's one of the most common ones and ones that you guys will be seeing a lot, and then we'll discuss briefly renal cell and bladder cancer and then testicular. So starting with prostate cancer, here's some of the risk factors for development of prostate cancer. Okay, age, race. We know that African American men are more prone to get it, and when they do get it, they're more prone to have an aggressive course. Family history. And interestingly, there's no known association between BPH and subsequent development of prostate cancer. So just remember that for your boards. And vasectomy also is not a risk factor. There are some reports of perhaps people with vasectomies getting, if they do get prostate cancer, a more aggressive form of it, but that's not necessarily borne out clinically. So for diagnosis of prostate cancer, we do what's called transrectal ultrasound. And you can see here, it's triggered either by an abnormal digital rectal examination or an elevated PSA greater than 4. You can consider it in people with a high PSA velocity, meaning that it's increasing rapidly over time. I know this is a controversial issue, but since we've got a lot to cover, I'm not going to spend too much time on it. And here is the ultrasound probe, so it's placed transrectally, and here's the needle. I don't know if you all can see that. And then you take representative samples. You want at least 10 cores, so at least 10 samples, and then, of course, any areas of abnormality that you felt, you'd want those also. And the main thing that the transrectal ultrasound and biopsy tells you is a very important piece of information called the Gleason score. So what the Gleason score is it's actually the sum of the two most dominant architectural patterns in the specimen. Okay, and it ranges from almost normal looking, adeno cells, which are nice and columnar, to which was graded as a 1, to all the way to a 5, which is just bizarre, and they're not even in any kind of glandular arrangement anymore. So, and that's reported. So for the first dominant pattern, most dominant pattern, you get 1 score, and then you get another for the second most in the sample, and then you add them together and get a full score. So if anyone ever tells you that somebody has a Gleason score of 7, an important thing to know is, was it a 4 plus 3 or was it a 3 plus 4? Because that makes a difference for them prognostically, whatever the most dominant histologic pattern was. Okay, and the higher the score, as you might imagine, the more undifferentiated and bizarre its growth, then the more likely it is that it's not confined to the prostate and has a higher propensity to metastasize. So that's one of the most crucial pieces of information. Other things that we do in our part of our staging workup are a bone scan and a CT scan of the abdomen and pelvis. The bone scan is because prostate cancer generally goes to the bone, and we do it if the PSA initially was greater than 10, because that is a sign, or not a sign, but a possible indicator that there might be occult bone metastases. And if the PSA is greater than 20, then we also add the CT abdomen and pelvis, because that increases the chances of detecting lymph node metastases. So not every single person that has prostate cancer needs to necessarily have a CT of the abdomen and pelvis. It really depends on what their initial presenting parameters were. PET scans are actually not done in prostate cancer. We're working on different tracers right now, looking to see if they can help us, but traditional PET scans are generally not ordered in prostate cancer. So one of the things about prostate cancer is it would be wonderful if we could use that information, just the scans and the transrectal ultrasound, and try to decide whether or not that prostate cancer is confined to the prostate gland or not. That's really, in all of our discussion about prostate cancer, the crux of the discussion, the most crucial thing is whether or not the cancer is limited to the gland. Because if the cancer is limited to the gland, whatever you do, whatever prostate-directed therapy you do, has a more than 90% chance of working. But if there's even one cell that has breached that capsule, if you do just a prostate-directed therapy, of course, the chances of it coming back are very high. right? So that's the most important thing when we're trying to figure out what treatment should we do. And if we could look at just a CT scan and see that, that would be great, but that's not possible. If we could do just the transrectal ultrasound and be able to delineate that, that would be great. But again, imaging modalities in prostate cancer just aren't all that. They're useful to some extent if they're big macrometastases, but they can't help us with the micrometastases. So what do we do then? What we do is we put all those pieces of information together and we develop a risk stratification system. So on the right side of the screen, you see here there's low, intermediate, and high risk. And what those risks represent is if you do just a prostate-directed therapy, what is the risk that that cancer will come back? Okay? So let's start here. If you had a Gleason score between 2 and 6, right, pretty well differentiated, and a PSA less than 10, if you do just a prostate-directed therapy, your risk of it recurring is low. Let's go to high. If you have any lymph node metastases, which is a stage 4 in prostate cancer, or any distant metastases, or any locally advanced disease, then if you do just a prostate-directed therapy, your risk is very high of recurring, right? So this is our risk stratification. We incorporate all these pieces of information, and even then it's not perfect. We're in terms of predicting who will have a recurrence and who won't, but this helps us refine it more so than just doing scans and just doing the Gleason score. Okay, so here's our treatment overview that I wanted to go over for prostate cancer. If it's organ confined based on our risk stratification system, so low Gleason score, low PSA, then we have plenty of things that we can do. We can do active surveillance. We can do a radical prostatectomy to remove the gland. We can do brachytherapy, which is implantation of radioactive seeds. And we can do external beam radiotherapy, which is, as it sounds, external radiation versus seeds being implanted. Now, if it still appears to be organ confined or high risk, or there's extraprostatic extension, meaning it seems to be organ confined based on scans, but the Gleason score is greater than 8 or the PSA is greater than 20, or there's any lymph node involvement, then you can't just do prostate-directed therapy. What you have to do is prostate-directed therapy plus an additional therapy, which in this case is androgen deprivation. We're going to talk more about these modalities relatively quickly, but soon. And then, of course, if there's lymph node involvement, again, you can't just do prostate-directed therapy, right? You have to do prostate-directed therapy plus androgen deprivation therapy. Now, if at the get-go there's metastatic disease, so when you did your CAT scan, for example, you found bony metastases, you wouldn't do a prostate-directed therapy unless you needed to do a TURP or something like that to help with lower urinary tract obstructive symptoms. You would go to full systemic therapy with androgen deprivation. Okay, so let's talk again very briefly about the different modalities. And let's start with active surveillance because it's really underused in prostate cancer. So active surveillance is very appropriate for those people that we discussed were low risk, right? Low Gleason score, low PSA, especially if they have a lot of comorbidities or their life expectancy is less than 10 years. And what does active surveillance involve? Well, it's actually, you have to check your PSAs every 3 to 6 months, and what you're looking for are a PSA doubling time to be less than 3 years, because that's somebody whose disease activity is accelerating and somebody who may potentially require an intervention. Other things are a digital rectal examination every year. You also want to repeat a prostate biopsy. If your initial transrectal ultrasound had less than 10 cores, remember we said that a good prostate sample has to have 10 cores. If it had less than 10 and you want to do active surveillance, you have to repeat a biopsy. Okay? And that would be at 6 months. If you had greater than 10, then you repeat that, at 18 months. And thereafter, you repeat biopsies every several years so that what you're trying to detect is evidence of the disease actually becoming biologically more active so that now you know is an appropriate time to intervene if the patient's status otherwise warrants it. Okay. Now, if you have localized disease and active surveillance is either not an option for the patient, or you don't think it's appropriate, then you move on to actual prostate-directed therapies. So radical prostatectomy, it's usually done in the with a retropubic approach, and you also do a pelvic lymph node dissection based on whether or not you suspect there to be lymph node metastases. You can see here the complications. Your operative mortality is about 0.5%. Erectile dysfunction is about 70%. Urinary incontinence about 1 to 2%. There is something, and we do it here at our center, called the Da Vinci robot, which is instead of doing an open radical prostatectomy, it's called minimally invasive. So the length of stay is shorter in that situation, but there can be some increased complications in terms of incontinence and impotence. And depending on how well trained the center's urologists are in doing it, you will have different outcomes. There's no head-to-heads comparing minimally invasive versus open. So the next thing is external beam radiotherapy. So it's crucial for treatment to be done to adequate doses. So in this case, it's 78 gray. And it also has, of course, its share of side effects. Radiation always does. It's mainly going to be gastrointestinal, so radiation proctitis. It generally resolves within 3 to 8 weeks. But also erectile dysfunction. Remember in prostatectomies we said it was about 70%? Well, in radiotherapy it's more along the lines of 40%, 30 to 45%. But the difference is that in surgery, you may have a higher rate of erectile dysfunction, but it actually your function improves over time. Whereas in radiation, it's kind of the opposite. So your function actually worsens over time as those tissues around the nerves fibrose. Okay, and so one of the things though about radiation is that if you do have erectile dysfunction, phosphodiesterase inhibitors do work better in that setting. And it's contraindicated in people who've had previous pelvic irradiation or inflammatory bowel disease. So surgery and radiation are two equally good options as a prostate-directed therapy. Surgery may have more, erectile dysfunction potentially, and radiation may have more GI complications. External beam radiation. There's also brachytherapy. So external beam radiation takes about 6 to 8 weeks. But brachytherapy is a one-day procedure. They actually implant these seeds. They're about the size of an uncooked grain of rice, and they implant about 75 to 100 of them into the gland, and it's a one-day procedure. They can use many things. You can use palladium. It was actually discovered by Marie Curie and her husband Pierre. So this is one of the most oldest cancer treatments, because when Marie Curie discovered polonium and radium, her husband actually, and she won the Nobel Prize for that, her husband actually looked and saw that if you implanted those into a tumor, you could potentially cause tumor death. So this is an idea that really has its roots in the very infancy of radiation oncology and maybe all of cancer treatment. So the disadvantages is that if you have a really large gland, then you're going to have to implant more of those seeds, and they will decay over time, but they can cause acute urinary retention. And you're still not completely free from other radiation side effects like proctitis, because that still does happen, though at a lesser rate. So how do we decide what treatment modality to recommend? Okay, so we said that all of them are, if it's low risk, confined to the gland based on what we know from the PSA and the Gleason score and all of those things, and the transrectal ultrasound, then if all of these things are, if it's confined within the gland, then any prostate-directed therapy should work equally well. And so what we do is there is a nomogram that you put in all of these pieces of information. It's called the Memorial Sloan Kettering nomogram, and they'll actually give you your 10-year recurrence-free survival. Almost all of them are going to have the same overall survival. So what we're interested in, which of these modalities will give you the best chance of recurrence-free survival. So most of the time what really happens is, when if they come to see us and we talk to them about the different side effects, or they already have it in their mind which one they want. But there is a nomogram to help you decide. Okay, so we talked about low-risk disease. Now let's move on to intermediate risk disease and high-risk disease. So intermediate risk disease, you can see here your Gleason score is starting to be 7, PSA is 10 to 20. In high-risk disease, your Gleason score is high at 8 to 10, and your PSA is high at greater than 20. Okay, so and you'll see here that any lymph node involvement is considered very high, which makes sense, right? And all of these things are actually treated relatively the same, depending on their age. So all of them will have a local therapy, external beam radiation, and androgen deprivation therapy for about 2 years. We call that long-term androgen deprivation therapy. So it's 2 years. Okay, so we never do surgery and long-term androgen deprivation therapy. That actually worsens outcomes. If you have locally advanced disease, or based on these parameters that you're either intermediate or high risk for recurrence, you do external beam radiotherapy and 2 years of androgen deprivation therapy. Okay, so you never do surgery and androgen deprivation therapy. Then next, if you're very high, which is metastatic disease essentially, then you do androgen deprivation therapy by itself. So I put this slide in here just because when you all rotate with us in clinic, so you'll have an idea of what we do. If you've done a locally directed therapy to the prostate, which was low risk for recurrence, then how do you do surveillance? You do PSA determinations about every 3 months for 2 years, then every 6 months until you've done 5 years, and then annually. So if you did I'll go back to this. If you did do a locally directed therapy and you either did surgery, then your PSA should be 0, right? You've removed the prostate gland in its entirety. If it was organ confined, your PSA should be 0. So in 1 month, if your PSA was 100 and then a month later after surgery, it's down to 2, that's still not a very satisfying outcome. It should be 0. Now radiation, on the other hand, if that was your prostate-directed therapy that you did, you may not necessarily ever get to 0. In fact, it may take 18 months to reach your nadir, which is the lowest your PSA will go. It might be 2, it might be 0.2. But every other PSA determination is done in relation to that PSA nadir. So after surgery should be 0, after radiation you reach your nadir, and then you do surveillance after that. So if your PSA does grow up after a locally directed therapy, then what you do really depends on whether or not you have detectable lesions on scans. If you don't have any detectable lesions on scans, we call that a biochemical relapse. Okay, the relapse may be occurring, it probably is occurring, but all you have is biochemical evidence, which is a PSA increase. If you do scans for a PSA increase after a locally directed therapy and you see lesions, then we treat that as advanced disease and start androgen deprivation therapy. Okay. So you do androgen deprivation therapy as a sole modality in 2 settings. You've done your locally directed therapy and your PSA, you're doing surveillance every 3 months for the first 2 years, then every 6 months until 5, and then annually, and your PSA goes up and you see lesions on scans when you scan them again. Usually you do a CT scan of the abdomen, pelvis, and a bone scan. Or from the very beginning, when you first diagnosed their prostate cancer, they had metastatic disease. So you do androgen deprivation therapy as your modality. Before I discuss androgen deprivation, I want to talk about metastatic prostate cancer. It generally goes to the bones, lymph nodes, occasionally liver. There is an entity of prostate cancer where you won't see an increase in the PSA, but you do have metastatic prostate cancer, and that's called small cell dedifferentiation. So essentially it's starting to act like the cancer cells have become so bizarre in their growth pattern that they've dedifferentiated from an adenocarcinoma and now are behaving like a small cell. So you may not see a PSA increase, but you'll see increase in bone metastases or liver metastases and things like that, and certainly is accompanied by symptoms. Okay. So treatment of metastatic disease. We've mentioned androgen deprivation therapy before, but what is it actually? So anything that decreases your body's testosterone levels is androgen deprivation therapy, right? It can be accomplished many ways. Surgically is the quickest way to achieve it. In Europe, they don't actually give you a choice. Anyone who has metastatic prostate cancer or advanced disease gets orchiectomy. If somebody's in the hospital and they're presenting with really obstructive symptoms, either spinal cord compression from bony metastases or urinary obstruction, and you need to get their PSA down quickly, consulting urology for an orchiectomy is actually the best way to go. Okay. Otherwise, there are other options to affect androgen deprivation. One of them is using an LHRH agonist. Okay. And you all probably remember from studying for boards why this would work. Why would an agonist actually decrease testosterone production? And the answer to that is because it's interfering with the pulsatile release. So initially, you will see an increase in the LH and FSH with an initial, what we call flare in testosterone. Okay? But then over time, because you've interfered with their feedback loops, it decreases testosterone. So if somebody does have symptoms and you give them an LHRH agonist by itself, because of that initial flare, you could actually potentiate them having worse symptoms. And so if you do that by itself, consider adding an anti-androgen, which actually interferes with testosterone binding to the androgen receptor. You do it for a short course, bicalutamide, about 50 milligrams a day for 7 days, overlapping with the LHRH agonist. Okay. Then we talked about anti-androgens, which are things like bicalutamide, interfere with binding to the androgen receptor. You can use high-dose estrogens. You can use ketoconazole. There are a myriad number of options. Ketoconazole and estrogens, of course, have their own host of side effects. So now with better options, those aren't really used. They're just historical. One interesting thing is combined androgen blockade, where you use an LHRH agonist to interfere with the feedback loops and an anti-androgen simultaneously. If you're doing it to suppress a flare, then that's a good use of an anti-androgen. But using them together, actually, paradoxically, in the beginning may have a good effect, but paradoxically over time, your body upregulates its androgen receptor, and actually you see worsening PSA response. So a combined androgen blockade not only has increased cost, bicalutamide is actually very expensive, increased cost, increased side effects, and over time decreased effect. So unless there's really a compelling reason to do it, most people do not advocate using combined androgen blockade. Side effects of androgen deprivation therapy, again, are many. Most of them center around vasomotor symptoms like hot flashes, erectile dysfunction, osteoporosis. So everyone has to be on calcium and vitamin D and get a baseline DEXA scan. And if they already have osteopenia, then we put them either on a bisphosphonate or a RANKL inhibitor. There is actually, when somebody starts androgen deprivation therapy, a 20% chance that they will develop fractures at 5 years. So it's serious. There are other things that are more difficult to quantify, things that, emotional lability. Men need to be told they expect certain body changes, decrease in lean muscle mass, increase in fat, decrease in testicular size, possible increase in breast tissue, and possible pain. And there's also more recent data coming out now about an actual association with dementia in androgen deprivation therapy use. So that's something else that needs to be discussed with patients. And of course, most of the time when we're advocating using this in the advanced disease setting, we're doing it for a compelling reason. So a lot of these side effects, though unpleasant, are some of the things we must accept. Just recently, there was a lot of interest in the concept of continuous versus intermittent androgen deprivation. The idea being that we talked about all those side effects. So if there was a way that we could give somebody a break in advanced disease, let them, get some of their functioning back and just their general, mood and well-being back, then what if instead of continuously giving it, there's different administrations of androgen deprivation. For example, LHRH agonists, you can give them every month, you can give them every 3, every 6, but whatever you do, or even a depot every year. But whatever it is you do, if you give them a break instead of doing it continuously, then the other thinking behind it and why there was so much excitement was because they thought, well, if you give the prostate cancer cells a chance to actually differentiate more, and then hit by giving it intermittently, like say give it a 6-month break, and then give it again, then your amount of cells that you're killing is actually higher. However, when they actually looked at the clinical trials, and this was one of the seminal trials for that, the SWOG 9346, it was a non-inferiority trial. And they found that if you had minimal disease, so just a small amount of disease burden, doing intermittent versus continuous was non-inferior. However, if you actually had high burden of disease, if you only did intermittent, you had worse outcomes. It was not non-inferior. In oncology, we like to use terms like that. So, briefly about bone-modifying agents, zoledronic acid and denosumab. If you're using it in the hormone-sensitive phase, meaning if you're treating prostate cancer, metastatic prostate cancer with an LHRH agonist, you actually don't need to put them, if they have bony metastases, on any of these bone-modifying agents, unless they have osteopenia. If they don't have osteopenia, then the treatment for the bone-modifying treatment is the LHRH agonist. Okay, so you don't need to do it in this setting. So what happens, though, if you have metastatic disease and you start them on androgen deprivation? How long does that phase generally last? Well, it lasts approximately, of course, there's going to be very wide variation in this, about 2 years. And then, this is metastatic disease. So what happens is the prostate cancer cells undergo mutations where they're no longer as reliant on serum testosterone. We call this phase castrate resistant. So even though your body's castrate, meaning your serum testosterone levels are less than 50, the prostate cancer cells are still finding a way to grow. In the past, we used to call this androgen-independent prostate cancer, but we changed the name when we realized that this is still a largely hormone-driven process. It's still largely testosterone-driven. And this phase, this castrate-resistant phase, it's called CRPC, is the acronym, lasts on average about 12 to 18 months. What's happening as we've elucidated more and more about the androgen receptor is that several things are happening. The prostate cancer cells themselves are producing testosterone. There's extragonadal sites of testosterone production, for example, the adrenal gland. And the androgen receptor itself is undergoing changes, mutations, that's letting it stay constitutively active, even with low levels of serum testosterone. So, treatment at this phase actually involves, most of the time we leave the androgen deprivation therapy on because there's still a population of cells that in the prostate and in the lesions that are reliant on testosterone. So we leave that, but we have to add something else. And that something else capitalizes on the fact that we know it's still an androgen-dependent process. So what we do are drugs I've listed here. You can see Sipuleucel T, which is immune therapy. That's the big buzzword in all cancer therapies now. It really has its best effect in patients who are minimally symptomatic. Okay, I have a lot to cover, and I would like to go through the mechanism of how it's done, but it is an arduous process because it involves going to the Red Cross, doing leukapheresis, exposing those cells to the antigen, and then redirecting it back into your body. So it's a lot. You do 3 courses of it. And again, in clinical trials, it was compared to placebo and shown to have a several-month survival advantage over placebo. It was 27 versus 24 months, for example. So think about it. These patients had metastatic prostate cancer, progressed from the hormone-sensitive phase now to the castrate-resistant phase, and all you did was give them a placebo, and they still had an approximate 24-month median survival. And so adding 3 months onto that with this arduous therapy, is in the cancer community kind of controversial. Of course, patients, always want to try things that have big buzzwords like immune therapy, so it's always at the forefront of what we offer, but it should be discussed, the context in which it got its approval. Okay. Other options are things like abiraterone and enzalutamide. So abiraterone is actually a CYP450p17 enzyme inhibitor, and that's crucial in extragonadal androgen synthesis. So if your serum testosterone with an LHRH agonist is about 40 to 50, if you use abiraterone, that goes down to about 1 to 2 nanograms per deciliter. So you're really decreasing your testosterone when you use abiraterone. So it's a pill. It's given four pills every day, and it's oral, so that's convenient. Its main side effects, and you all may see this, are actually tachycardia and atrial fibrillation. It can cause mineralocorticoid problems. You can see edema, hypertension, things like that. And the other option, abiraterone has been approved first line in castrate-resistant prostate cancer. So this one decreases extragonadal synthesis of testosterone. Enzalutamide is actually an irreversible inhibitor. It irreversibly binds to the testosterone, to the androgen receptor. Remember we talked about anti-androgens? Well, those are reversible. They reversibly bind to the androgen receptor. But enzalutamide irreversibly binds to the androgen receptor. So one thing I forgot to mention about abiraterone is it can cause hepatotoxicity, and so you have to be monitored very frequently for that. Enzalutamide is also oral and also convenient for that reason. They're both approved for first line. Enzalutamide's main side effect is fatigue, pretty profound fatigue, but otherwise both equally well tolerated. The reason these are up here, docetaxel and cabazitaxel, is because for many, many years, really, those were the only options we had in castrate-resistant prostate cancer. We only had cytotoxic chemotherapy. And it did have a demonstrable benefit, but it's still, it was still lacking in terms of its overall efficacy. So docetaxel is a synthetic taxane. Cabazitaxel is an even more refined version of docetaxel, and both of them can be used. If you have disease that is growing very rapidly and needs to be rapidly controlled, then cytotoxic chemotherapy may be the first option, just because you can try to decrease their tumor burden quickly. Otherwise, you have these oral options, and you use them in sequence. And you monitor their PSAs, and if they increase, you do scans and you see worsening lesions, then you change to the next agent. Okay. Another new agent, and I'm sorry I'm spending so much time on prostate cancer, it's just that a lot of new agents have gotten recent FDA approval, and I wanted you all to be aware of them, because you probably will have patients who are either getting them or will be. Radium-223 is another drug that it actually emits alpha radiation, so it's great for patients who have castrate-resistant prostate cancer with predominantly bony metastases, actually only bony metastases in the clinical trial. And especially if they have symptoms from those bony mets, they found that compared to best supportive care, they'd actually, if you do radium-223, that you decrease your risk of death by 30%. Now, granted, a lot of these therapies, best supportive care, glucocorticoids, diethylstilbestrol, estramustine, are not exactly very potent agents. So showing a 30% relative risk reduction compared to these is not necessarily standard, but nevertheless, it was there, it was demonstrable, and median survival was longer by 3.6 months. So one of the things with radium-223 is if they have any CBC abnormalities, because it's acting directly on the bone, they're not eligible for that. So this is just a treatment overview. I'm actually going to move on to renal cell carcinoma. There's several subtypes of renal cell carcinoma. The most common is clear cell, 70 to 80%. There's also papillary, and papillary there's two types, type 1 and type 2. Type 2 is more aggressive. Type 1 is characterized by the MET oncogene. And there's chromophobe and collecting duct, and medullary, which is seen in sickle cell trait and has a more aggressive course. Some of the risk factors: smoking, acquired cystic disease, and von Hippel-Lindau disease. So, this is usually present on the boards in some form, that it affects chromosome 3. It's either a mutation in chromosome 3, and these individuals actually get a second hit that actually leads to development of retinal angiomas, cerebral hemangioblastomas, things like that, pheochromocytomas, and clear cell renal cell carcinomas. The vast majority of renal cell carcinoma is clear cell, so for the rest of this discussion, when we talk about treatment, most trials were designed to look at clear cell, so that we'll be limiting our discussion to clear cell. So how do we stage renal cell carcinoma? It's actually done by CT of abdomen, pelvis, or an MRI. An MRI if you're wanting to get better delineation of the venous structures. A chest x-ray or a CT chest if the tumor is large. And you really only do bone scans and those sorts of things if they have symptoms, if they have an elevated alk phos or hypercalcemia, and an MRI of the brain if they have CNS symptoms. PET is actually not very useful in this regard either, because it's not a very fast-growing tumor, or at least most of the cells are not very fast-growing in them. Now, one thing that often comes up in patients who have newly diagnosed renal cell carcinoma is the fact that a lot of venous structures are often involved by the tumor. So there's a tumor thrombus, and then it's hard to differentiate, is this just tumor thrombus? Is there also bland thrombus involved? Often the two almost always coexist, and the only way to really know which was which is by resecting it and looking, if you chose to. So, of course, tumor thrombus, we hope, will enhance on scans, just like the rest of the tumor in the kidney, but still it's hard to tell whether it is bland thrombus or just tumor. Again, like I said, they're almost always admixed, and so the question always comes up, well, should we anticoagulate? And the answer to that, and I'm in the interest of time oversimplifying this answer, but the answer is no. Because if you anticoagulate in this setting, you're actually making it very difficult for the urologist to resect it, because they're going to try to resect the thrombus in addition to the primary tumor. Okay? Of course, there's always, every time I attend, there's always subtleties in this, because sometimes that person has a history of VTE, or sometimes they came in with VTE symptoms, and in that situation you just have to adjust your decision tree about how you want to proceed. But generally speaking, you don't anticoagulate in this situation. And here's a graphic representation of the stages of renal cell. This is Gerota's fascia, and that's the most critical thing about whether or not it stayed within the kidney capsule or not. So stage 1 disease, this you can see there's purple, it's less than 7 centimeters and limited to the kidney. Pretty good overall survival in general in these people, 95%. Stage 2 is greater than 7 centimeters, but still once again confined to the kidney. Stage 3 is tumor in the major veins or involving the adrenal. Their survival drops off to about 60%. And then stage 4 disease is any tumor, we said, beyond this Gerota's fascia. And treatment is a radical nephrectomy. So basically removing as much as you can of the entire tumor and lymph node dissection to the renal hilum. If you have a small lesion, you can do a partial nephrectomy, small meaning less than 4 centimeters. And post-treatment surveillance, and moving through it quickly, it really depends on what you found at your nephrectomy and the different, whether or not you found differentiation and things like that. But you generally do a CT scan of the abdomen and a chest x-ray every 6 months for 3 years, and then annually for a total of 9 years. Renal cell carcinoma is one of those that can come back, that can recur even after 9 years, but really there's a long period of time from which it can recur. We use the UCLA, like I said, for surveillance, we use the UCLA integrated staging system, but so treatment of metastatic disease. Renal cell carcinoma, unfortunately, does present with metastatic disease a fair percentage of the time, and it generally can go anywhere, really. It can go to the lungs, it can go to the adrenal, the CNS, and it's relatively chemo-resistant, meaning traditional cytotoxic chemotherapies just simply don't work well in renal cell carcinoma. But what does work well is immunotherapy. And there have been many, many new immunotherapy options. There's also been TKIs, tyrosine kinase inhibitors, small molecule TKIs. Renal cell carcinoma is really a shining example for us in the oncology world of how our deeper understanding of the biology of the way the tumors progress has let us tailor treatment to it. So instead of doing cytotoxic chemotherapy, traditional chemotherapy agents, which is basically an all-out assault, this is trying to target the pathways more. So targeting VEGF pathway, targeting the mTOR pathway, targeting PD-L1. So I'm going to talk about some of these immunotherapy options here shortly, but one of the things about metastatic renal cell carcinoma that's also different than other tumor types is that there is a role for removal of the kidney. In most metastatic cancers, it's really removing the primary site once you've already developed metastases was kind of is against dogma. But in renal cell carcinoma, because it's so immunogenic, if you can remove the vast majority, the bulk of the tumor, you can actually enhance your response, because it's hard for your own immune system to tackle a big 7-centimeter mass. It does better when it does smaller deposits. Okay, so renal cell carcinoma, if you can, it's a good idea to, even in the metastatic setting, to call a urologist and ask if they can debulk it. Debulking means they feel like they can get at least 75% of that tumor out. Then that's worth doing, even in the metastatic setting. Okay. So there are many, as a clinician, there are many options in terms of VEGF TKIs. There's sunitinib, sorafenib, axitinib. Then there's mTOR inhibitors like everolimus, temsirolimus. So essentially, you can do any of those in any sequence you want. There's also what you all may have, when rotating through us with us, seen called high-dose IL-2. Okay, so high-dose IL-2, again, IL-2 is basically giving your immune system a boost. Okay, so just like we give it in terms of 750,000 international units, and it's given every 8 hours. You have to be in an intensive care unit setting because you're really propelling that immune system 10 times from baseline, and you can have significant side effects like hypotension, capillary leak, mental status changes, delirium, a whole host of things. So and you need to be in an intensive care unit to be administered that. So you might be asking, well, why would you give somebody with metastatic cancer this extremely potentially toxic treatment that could lead to unacceptable side effects and things like that? And the answer to that is it's the only treatment in this setting that's been shown to have a durable complete response in about 3 to 5% of patients. So a complete response, right, is all radiographic evidence of disease disappearing. But what's crucial is a durable complete response. Because if you have a complete response and it lasts 1 month, then it wasn't really worth very much. But a durable complete response, and some of the patients in the clinical trials had it for more than 51 months. That's worthwhile. So 3 to 5% of patients who got high-dose IL-2 had a durable complete response. And in somebody who has metastatic cancer, that's something worth trying for if they have no major comorbidities and they're relatively young and they can handle this. So some centers, depending on their patient selection, can actually show better numbers than that. But otherwise, 3 to 5% is about accepted. The other immunotherapy option is nivolumab, which has just recently been approved for renal cell carcinoma, and it capitalizes on blocking the action of the programmed death pathway, basically releasing the inhibitory effect on the immune system so your own immune system can attack the cancer cells. And actually, with some pretty good responses. There was about 15% partial response in the second-line setting after they've already failed a VEGF TKI. So it's hard in renal cell carcinoma to really get a good gauge on whether or not the patient's responding or not. Because of the immunogenic nature of it, some of these lesions could actually look larger on scans because the cells are lysing, they're dying, your immune system's bringing in all these other cells, all these fluids, all these things. So there's an entity called pseudoprogression where the patient's symptoms are actually getting better, but their scans are looking worse. And so if you're ever given a scenario like that on the boards, then the answer to that is to continue the treatment. In fact, in oncology, at any time on your boards they say the scans are looking worse, but the patient is doing better, the answer is to continue the treatment. So this is another entity of example of pseudoprogression where it's actually just inflammation making those lesions look bigger. But let's go through bladder cancer quickly. Here are some of the risk factors, and one of these, smoking, of course, increases your risk, as it does to most cancers, and there's also a field cancerization effect, which is that you can have cancer again in that same area, even if you've done a removal of that primary. Then and the entire tract, actually, the upper tracts, ureters, things like that. Then there's occupational exposure, so especially dye, rubber, and aluminum, exposure to aromatic amines. Then schistosoma infection, which actually occurs more commonly in areas like Egypt and is associated with squamous cell carcinoma of the bladder, unlike traditional transitional cell or urothelial carcinoma. And then cyclophosphamide is one of the known, it causes hemorrhagic cystitis and subsequently bladder cancer. So the diagnosis of bladder cancer, and for the rest of this discussion, we're going to stick with just traditional urothelial transitional cell bladder cancer and not talk about squamous. The diagnosis is done generally by, usually it's males presenting with, or females presenting with painless hematuria. You do cystoscopy, which is where you do a direct visualization of the bladder, and then you do cytology of the urine, CT abdomen and pelvis, and the chest x-ray. If there's any nodal disease present in the CT of the abdomen and pelvis, then you do a CT chest. Otherwise, you do chest x-rays. And once again, bone scans really for advanced tumor, locally advanced tumors or symptoms or increased alpha phos. PET scan, once again, in this, it's better in bladder than it is in renal cell or prostate, but again, it's really mostly useful in the metastatic setting. I talked about the different types. Very rarely it can also be adenocarcinoma. There's two major categories of bladder cancer. Okay, and the two categories are superficial and muscle invasive. Muscle invasive meaning the actual muscular part of the bladder. Right. So here's the different layers. Here's the ureter. There's the outer muscular layer in the dark purple, the inner muscular layer, and then the lamina propria. So whether or not this tumor has breached the lamina propria and come into the muscular layer makes all the difference in terms of how we treat them. If they are lamina propria or above, they're considered superficial. If they have, even if one tiny cell has penetrated that muscular layer, it's considered muscle invasive and has to be treated much more aggressively because it has a much higher risk of recurrence. And when it does recur, it recurs in a widely spread metastatic fashion. Okay, so basically any muscle invasive disease is considered stage 2. Okay, stage 3 disease is anything that's outside the bladder. Again, very high risk for recurrence if you only do bladder-directed therapy. And stage 4 in bladder, as it was in prostate, any lymph node involvement automatically makes it stage 4, and of course any distant disease. So superficial bladder cancers, we said anything lamina propria and above. 70% of bladder cancers are superficial, and almost 70 to 75%, even after removal by a urologist, will recur over the next 5 years. And TURBT stands for transurethral resection of the bladder tumor. We'll be using that acronym more later. So, and of these superficial bladder cancers, the 70% that are superficial, about a quarter of them will progress to muscle invasive. 3/4 of them will just be superficial, and you'll have to just go and get them, go through a TURBT if it's discovered that it's recurred by your urologist. Now, muscle invasive bladder cancer so superficial bladder cancer is a urologically managed issue. Muscle invasive bladder cancer is where medical oncologists step in. Because like we said, if you do just a bladder-directed therapy, just a radical cystectomy, removal of the entire bladder, just based on the fact that even one cell has invaded the muscular layer of that bladder, your risk of recurrence is like 50% at 5 years. That's pretty abysmal, right? You take out the entire bladder, and still 50% of the time at 5 years, you're recurring, and most of the time distant mets. So the main treatment issue, the main paradigm in treating bladder cancer is to try to decrease those distant mets and try to refine who we can do just a radical cystectomy in and who needs additional therapy. Okay. So because of that 50% recurrence at 5 years, we did in the past adjuvant chemotherapy after bladder cancer, if you knew that it was invading the muscle, was given. Now, there's many intricacies that I won't get into, but it didn't show any survival benefit in the adjuvant setting. Adjuvant means any therapy that's given after a presumed curative therapy. Neoadjuvant is any therapy given before a curative therapy. So when they looked at bladder cancer and they gave them adjuvant, so after the cystectomy, chemotherapy, it didn't make any survival difference. However, if you gave it neoadjuvantly, so before you underwent this radical cystectomy, you actually did see a 5% 5-year overall survival benefit. Okay? Absolute survival benefit. Now, I understand to you all, 5% seems pretty paltry, but you have to understand that in oncology, that's hallelujah jubilation dancing in the streets, okay? Because it's a 5-year absolute survival benefit in 5%. Okay? So neoadjuvant chemotherapy is usually delivered with a chemotherapy regimen called MVAC, which we'll go through, or gemcitabine cisplatin, but whatever it is, cytotoxic chemotherapy given neoadjuvantly. And there's different things that have to factor into play. For example, from your time of diagnosis to your radical cystectomy, no more than 12 weeks should elapse. Okay, so if you give chemotherapy neoadjuvantly, and it's given every 3 weeks or 4 weeks, depending on which regimen you choose, and then you have to delay them for cytopenias or other toxicities, then by the time, if you don't deliver that chemotherapy and have them in shape for surgery and more than 12 weeks has elapsed, then you've actually decreased their survival outcomes. So no more than 12 weeks have to elapse. So when you first see the patient, you have to decide, you have to talk with them, assess their comorbidities, their general functional status, their social support, all of those things, and see whether or not they would be a good candidate for neoadjuvant chemotherapy, or whether, based on their other parameters, you're actually going to be delaying their cystectomy, their actual curative treatment. Okay? And if somebody has, and in the clinical trials, about 38% of the time, and these were well-selected patients, of course, there was actually a complete response just to the neoadjuvant chemotherapy. And some patients said, well, in that case, I want to keep my bladder because I don't want an external appliance. I don't want, all of the other surgeries that may go along with it. But that actually is not an acceptable cancer therapy. It's just chemotherapy by itself, it will recur. You must do an actual primary bladder-directed therapy in addition. Okay. So a radical cystectomy, you can see here, described it in men and women, what it entails, and it's a big surgery. It's major abdominal surgery. And then the second issue, which becomes, well, what do we do in terms of creating a urinary diversion? There's 3 different types. There's a non-continent cutaneous diversion, which is essentially they bring a loop of bowel connected to the ureters, and they bring it to a stoma to the skin, and then you have an external appliance, a bag that collects the urine. Secondly, you have a cutaneous continent reservoir, and they actually build a continent reservoir, and it's called cutaneous because the patient actually has to self-catheterize, and it's usually through their umbilicus. Okay, so at varying intervals. And then the last and most attractive option is called an orthotopic neobladder, meaning they actually use their own tissues to try to fashion a bladder. And it has to be a surgeon especially trained in urologic malignancies, and it's a lengthy surgery, and not everyone's a candidate based on their locally advanced features, but that's an option also. We talked about the neoadjuvant chemotherapy and adjuvant. Most of them are a regimen called MVAC, which is, you can see here, methotrexate, vinblastine, adriamycin, and cisplatin. So drugs with a lot of toxicities, and you have to be mindful of that. But here's what we were talking about. When you did MVAC and cystectomy neoadjuvantly versus cystectomy alone, you can see the big gap in there. Okay. Now, another thing that patients often ask about is, what about bladder preservation? Okay. I mean, it's true that having to remove your bladder is never an attractive option. That's absolutely true. However, bladder preservation also has its own pitfalls. And one of them is that it has a high risk of recurrence, and you have to do a lifetime surveillance with it, in terms of every 3 months intensive surveillance. And additionally, what bladder preservation is, you usually do radiation therapy in conjunction with some kind of cytotoxic chemotherapy, and it has to be preceded by a complete TURBT. meaning that the bladder tumor has to be completely resected, the part that the urologist can see when they do a cystoscopy, and then you can talk to them about keeping the rest of the bladder intact and then doing radiation plus chemotherapy. Usually use mitomycin C in that situation. You have to do lifelong surveillance. You can see here, I've put the percentages up, that 30 to 60% develop recurrent tumors, and that field cancerization effect that we discussed earlier is still present. So you can still develop another primary tumor because you've left that bladder in there. So yes, it's better than undergoing major surgery and potentially having to have an appliance, but it's not without its drawbacks. Okay. And then here's the surveillance schedule after treatment. Generally, it's every 6 months for 2 years, depending on whether or not it was organ confined or there was lymph node involvement. If it was not organ confined, as you can imagine, the surveillance is a little more intensive. Now, metastatic bladder cancer is also it's an incurable disease, and a lot of the same treatment regimens that we used in the neoadjuvant setting, they were actually gleaned from the metastatic setting. So generally have involvement in lymph nodes, lung, bone, liver, and chemotherapy does improve survival in this. The only thing is that there's different administration regimens for this. I won't go into all of it, but most of the chemotherapies that are used in this setting can cause neutropenia, myelosuppression, other toxicities. So in metastatic bladder cancer, what we try to do is give 4 cycles, a predetermined number of cycles of treatment, and do scans, and then just continue surveillance scans until we have to do another. It's not like most other types of solid tumors where, if it's having a response, let's just keep going. So in metastatic bladder cancer is one of those situations where you have a predetermined number of cycles that you're going to administer.